Constraint-induced movement therapy is a tool used to help increase functional mobility in the upper extremity after a stroke or other central nervous system damage. This rehabilitation involves constraining the unaffected arm to ensure the affected arm gets favoured when completing tasks. This goes against any kind of rehabilitation I have ever experienced, which is what sparked my interest. From an occupational therapy perspective, the research is intended to gain a better understanding of whether this form of therapy will increase a person's ability to actively participate in activities of daily living. The therapy was extremely occupation-based, as it constrains the unaffected limb in an attempt to allow the affected limb to be more active, to force the person to use it rather than favouring their stronger side. The search strategy included Google Scholar, the Cochrane Review, OT Seeker, occupational therapy journals from Australia and America. Constraint-induced movement therapy has been a topic of research for a long time, but as more and more information becomes available, the research is becoming a lot more specific. I chose to research the effect that constraint-induced movement therapy had on a person recovering from a stroke. A lot of research is more specific, or testing whether constraint-induced movement therapy worked in conjunction with other things. So the most recent systematic review I found was in 2011. The papers selected for this assignment consisted of one systematic review and 2 randomized control trials. The systematic review searched through 7 databases, and 5 different search terms were noted. Databases related to health science, and search terms were comprehensive. Overall search strategy was thorough. Inclusion was defined and had good guidelines to ensure the participants' characteristics were similar at baseline. Allowing any more variables would have made it hard to identify relevant RCTs, as well as being difficult to generalize over a specific stroke population. Overall, the inclusion criteria mentioned were reasonable and neither too broad or narrow. Exclusion criteria were not outlined. Conclusions of this systematic review matched the data given in the results section. Conclusions were reasonable and the hypotheses were supported. Comments on the implication for practice have been made and limitations were noted, which allowed for future research to be discussed. Turaya and Page published RCTs that both scored 6 out of 10 on the Pedro scale. According to the Pedro website, the average score is 4.9 out of 10, and a score equal to or above 6 on the Pedro scale means the paper is moderate to high quality. Both RCTs received the same scores for the same criteria. Subjects were randomly allocated to groups. Participants were similar at baseline, and assessors were blind during the experiments. Measures of all outcomes were obtained from more than 85% of subjects, meaning that dropout rate was low. The results for between-group statistical comparisons are reported, and the study provides both point measures and measures of variability. There were 3 obvious kinds of bias that could have affected the results. Publication bias. This could not be ruled out of the systematic review, and it's when results are published to answer a researcher's question, rather than publishing all available information. Social desirability bias. The systematic review in both RCTs used the motor activity log to test quality of movement as well as amount of use in the affected upper limb. This test involves self-reporting. This always increases the possibility of social desirability bias, which is when a person gives information they think the assessor wants to hear. Reporting bias. All 3 papers included a Fugel-Meyer assessment, which is a type of observer-initiated assessment. This can increase the likelihood of reporting bias when a researcher observes or reports information inaccurately. There were 3 main assessments that were used over the 3 papers. The Fugel-Meyer assessment evaluates and measures recovery in post-stroke patients. The systematic review reported that the 3 studies used FMA found significant heterogeneous mean differences. Taraya's RCT showed significant results in the FMA for the constraint-induced movement therapy group, compared to the control group, which was non-significant. Page's RCT found that the constraint-induced movement therapy group displayed collective mean improvements on the FMA. The time-matched rehab group and control group had less and non-significant changes. The Action Research Arm Test assesses upper limb functioning using observational methods. Significant mean differences were found in the systematic review. The most significant mean differences were in the papers that tested low-intensity constraint-induced movement therapy in favor of the experimental group. Page's RCT found group mean differences on the Action Research Arm Test. The control group and the time-matched rehab groups showed less improvement, which were non-significant. The motor activity log measures the amount of use and the quality of movement of the affected limb by self-report of the patient. The systematic review found significant homogeneous mean differences for quality of movement. The study testing low-intensity constraint-induced movement therapy found significant differences in favor of the experimental group. Taraya's RCT found non-significant improvements between the groups according to the amount of use and the quality of movement when using the motor activity log. These findings were the same at 1 week and 4-month follow-ups post-treatment. The significant findings of Taraya's RCT were found when comparing pre- and post-treatment using the motor activity log. The control group showed significant improvements at all initial follow-ups 1 week after treatment, but all improvements were non-significant after 4 months. Page's RCT found that after intervention, motor activity log scores increased for both amount of use and quality of movement scales, when only small changes were made for control groups. Analysis revealed significant pre-test, post-test changes in the motor activity log for the constraint-induced movement therapy group, but not in the other control groups. After analysing the papers and correlating the results, a general trend towards constraint-induced movement therapy as a significant therapy was found. All papers saw improvement in the more affected limb post-stroke at the end of the treatment period. When compared to a different therapy, constraint-induced movement therapy was significant across the board. Improvements on the quality of the movement made was the same across all 3 papers, yielding significance in all motor activity logs. The systematic review had findings that showed the importance of timing when administering constraint-induced movement therapy. It found that low-intensity constraint-induced movement therapy is more beneficial when used closely after stroke. It found that high-intensity constraint-induced movement therapy was detrimental to limb function and should be administered after more recovery. The 2 RCTs had at least 2 months recovery before treatment commenced, and more significant results were found in Taraya's paper 4 months post-treatment compared to 1 week. This has implications for practice, suggesting that constraint-induced movement therapy is more beneficial after some recovery, not immediately after stroke.